And without further ado, I'm going to turn it over to Tracy Delaney, and she'll lead us in.
Great. Thank you, Carla, and thank you, everybody, for joining us. Hope you had a wonderful weekend. We're happy to be able to host this webinar. There's a couple of new folks to our organization on the call, so I just want to spend a minute and explain who we are. We're the Public Health Alliance of Southern California, and we are a collaborative of local health departments here in Southern California. Collectively, our members are responsible for the health of nearly 60% of the state's population. And we're working on real upstream chronic disease prevention strategies, especially through policy, systems, and environmental change. So at one of our last meeting that was early in June at our Leadership Council meeting, we were talking a bit about accreditation, and our colleagues in Ventura had actually earlier this month became the first local health department in the state of California to receive national accreditation. So congratulations to Ventura and all the great work that they've done. Not only were they first out of the block, but they're also have been incredibly generous, sharing some of the experiences that they've gone through, giving us some tips. And out of that conversation, we had a presentation from both Ventura's Public Health Director, Mr. Rigo Vargas, and also Dr. Daniel Jordan, who's on the call with us now. They provided those insights, but a lot of folks were interested in learning more about the performance management system that they developed in working with the accreditation. So fortunately for us, Dan was kind enough to agree to do a little bit of a deeper dive into that and to present and answer some of your questions. And let me just briefly introduce him before I turn over the reins to him. So Dr. Daniel Jordan is the research psychologist for Ventura County Public Health and manager of the Healthy Communities Division. He led development of this coveted performance management system and has been working with his program staff to reevaluate what it means to do public health. He came to Ventura County in 1986 as the research analyst for the Mental Health Children Demonstration Project, and he helped turn this project into the California Systems of Care model, which is a nationally recognized model for interagency mental health systems. Dr. Jordan is a California licensed social psychologist and an organizational psychology diplomat with the American Board of Professional Psychology. His doctorate is from Claremont Graduate School. And although he's happy to be sharing this with you, he notes in his brief biographical sketch that he'd usually rather be sailing. And we can attest to that. At the bottom of his email signature, he has an interesting schematic that I think shares that sentiment. It took us a while to figure that out, Dan. But I think we finally got that on. Anyway, I'd like to turn it over to Dr. Jordan. And thank you, Dan, for joining us.
Well, thank you. And I'm trying to figure out who that old guy is in that picture, but that's okay. Okay, well, yes, thank you so much, and thanks for the opportunity to do this because, we did some things here that were a lot of hard work and very gratifying, to get our way through. And, just last week at the very last minute, I asked Carla to put on, the FAB logo showing that we are an accredited health department down there in the lower right corner. So, it's been good. So I guess I'm supposed to say next. Is that right, Carla?
That's right. And teacher voice, please.
Teacher voice. Okay. All right. Back to my teacher voice. Thank you. I teach part-time at Ventura College. The Performance Excellence Council, if you're familiar with FAB, you know that they have these domains. And Domain 9 was the performance management system, sad little acronym, and I won't figure it out. The people who were assigned to that domain in Ventura County, we assigned sets of managers to each of the domains in FAB. And, however it came up, we had, Bev Hansen, myself, and Lori Plunkett were the three people assigned to figure out FAB Domain 9. we looked at the domain and realized that there were a couple of domains in the requirements that you not only had to show your documentation of having done something, but you actually had to show that you had a system in place. And domain 9, the performance management system, is one of those domains. You had to show it, you've got the documentation that it exists and that it's actually functioning fully. And at the time, we did not have a system that fully met all of those requirements. So we built one. Then the public health accreditation leads were Rigo Vargas, our director, Steve Carroll from our EMS, Patty Chan from the Healthy Families, myself as a research psychologist and manager of the team, and Megan Steffi, our director of nursing. And all of the staff members of Ventura County Public Health who, it was an amazing amount of work. And, especially, get yourself a good coordinator. We had somebody who proved to be, a person who kept us all in line, kept us on task, and that's Sarah Mansfield, who I think I heard is on the call. And she just did a fabulous job of herding cats who wanted to run off in all sorts of different directions and kind of keeping us on task. It was an amazing amount of work. So, next slide. And if at any point anybody has any questions, let me know. So we had a long-standing continuous quality improvement committee. It functioned at an independent program level, and I'm not trying to be critical, but it was pretty much a siloed operation. We were kind of doing things programmatically. The projects were designed and implemented by line managers and staff who sometimes had little or no research, design, and evaluation experience. And that's just sort of some historical background there. Another thread that played into what was going on is that the county of Ventura at the county level, implemented Lean Six Sigma in a service excellence framework to try, and if people aren't familiar with Lean Six Sigma, it is its own version of a performance improvement toolbox, and I really refer to Lean Six Sigma as a toolbox. It's lean from Deming, if you're familiar with that. The work he did in Japan back in the the 30s and 40s and 50s. It's a way to improve efficiency. The phrase is eliminate waste, and the Six Sigma model is about effectiveness. So you put the two together, and you have a toolbox for assessing efficiency and effectiveness and improving your operations overall. We capitalized on that in public health. It's like now we have a requirement to have a system. The county has adopted a system, and rather than use something else, we decided to basically plug into the Lean Six Sigma model and the service excellence model that the county had already created, and use that toolbox to carry our method forward. Okay, next slide. So, pardon me again, a key point is that APHA Domain 9 required a functioning, integrated performance management system that went beyond what we had at the time. And I just want to kind of reinforce that particular point. And I know that 1.5 of the FAB requirements has changed, but I think it would still be a fully functioning, integrated performance management system. Next slide. So our barriers. The Turning Point Foundation identified 4 major barriers through research to reducing silos and creating integrated performance management. The first is a vision barrier. Only 5% of the workforce understands the idea of having a performance management system integrated to daily operations. A people barrier. Only 25% of managers have incentives linked to the strategic plan that the department has, if it has one. Management barrier. 85% of executive teams spend less than an hour per month discussing strategy. We're so caught up in daily crises, we don't have time to save time, if that makes sense. We're so caught up in doing the daily operations that we can't get around to shifting gears and thinking about how we can improve our operations. And the resource barrier is 60% of organizations don't link budgets to strategy. And I got the reference down at the bottom. It's the Balanced Scorecard Collaborative. Next slide. And more barriers. We have categorical funding forces siloing. The federal, state, grant, local supports, even the county general fund. I almost don't like to talk about public health department, and it's not just my experience here, but when I look around, we have public health amalgams of different pots of funding, different funding streams, different requirements. You have to make sure that you don't cross funding and cross tactics. Everything has to be in its own perfect little world, and you don't have a true single integrated operation, whether you call it an agency or department. We have changes in philosophy or siloing agencies from communities. Inform, educate, empower, and mobilize from our public health essential services has become inform, educate, and engage communities as passive recipients of our expertise. And in linguistic analysis, I find this shift in wording to be extremely important. It's called a discursive shift. And when I come at this from a critical discourse analysis kind of standpoint, something's really happened in the public health field that we no longer talk about empowering and mobilizing communities and instead engaging communities as passive recipients of our expertise. There's something very important that's happened there. It's just like in the issue of global warming. Back in 1998, someone came along on the, how shall we say delicately, the anti-science side of the camp and said, instead of calling this global warming, let's call it climate change, because climate change was found to have less impact on people's attitudes about what's really going on in the world. So again, there's a discursive shift that happens, and we need to pay attention to those things. And so it's a little bit of a sidelight, but I think it's very critical. So next slide. So to what extent does your department do this graphic? Now, I'm pretty willing to bet that most departments have this up as a poster somewhere on a wall, that we do assessment, policy development, and assurance. And then in assessment, we monitor the health of the community and diagnose and investigate and inform, educate, and empower and mobilize partnerships and develop policies and then make sure that everything's actually working. What I've come to realize is that most of our staff don't really understand what this means. And so we've also, just as a sidelight, we're putting the final touches on right now a new employee orientation for public health employees that orients them toward the ideas and the tasks and the strategies that are in this so-called set of essential services. Okay, next slide. Back in a year and a half ago now, the CDC held a community transformation grant conference in August in Atlanta, which was a good time to be in Atlanta. And in one of the sessions, this graphic was put up to show how the community transformation was to happen. And as soon as this went up, I just felt like my head wanted to explode. And I'll walk you through why I find this actually offensive. Okay, in the basic systems theory, inputs, throughputs, outputs, okay, at the top. And we're supposed to have a project through the Community Transformation Grant that leads to policy and environmental changes. However, the CDC was very clear during that entire conference that you were not allowed to talk about policy because talking about policy violated, and this is their language, not mine, and although it's true, violated states' rights. And I won't go too deep into that, but if you know the history of what it means to states' rights versus individual rights, rights of the nation, that's a pretty serious point. And then those policy changes that you're not allowed to talk about are supposed to lead to short-term access, availability, knowledge, and attitudes of individuals who then, all of these individuals collectively begin to change their behavior that lead to long-term health outcomes, that lead to chronic disease rates, changes in chronic disease rates. And the focus here, though, is on changing individual behavior. And I suggest that a focus in health education on changing individual behavior is not very effective, because if it were effective, we would not see the actual data that we see of the massive rates of increase in things like obesity and diabetes and all of the chronic diseases. So there's a fundamental flaw in this model from the beginning. And then oddly, at the bottom of the graphic, you see this box laying down there called community context that's not linked into anything. So after this particular session, I had drawn all over my paper copy of this thing and went to the presenter and suggested that there was an alternative that actually made a lot more sense. And I was told that while I was right that it made more sense, that the CDC would not allow them to change the graphic. And I'll show you the next slide then. So next, am I still loud enough? Okay,
yeah,
here's my complaint. Okay, here's my complaint. This is a downstream medical model, and if you're familiar with, the work of Anthony Aiton or Barhai up in the Bay Area, this is downstream. It's a medical model presentation. Then we'll go to the next slide. And here it was what I suggested as an alternative point of view, that we work on policy and environmental changes that inform, educate, and empower and mobilize communities back to our essential services that change community context, that lead to changes in individual behavior and lead to changes in the community that then all feed back in loops among themselves. Okay, so that's my aside and the way that I want to work upstream in public health. Next slide, please. So the results of all the barriers that we're confronting. We're all supposed to know and function out of a set of essential services that integrate public health philosophy, vision, mission, goals, all those things. These essential services are to create a partnership with the communities we serve. And when I do this as a presentation, we do an activity to compare our programs and services to the 10 essential services and identify the extent of the match. And I suggest that people take some time to do that and really look at strategies. Next slide. Okay, so what we needed was a coordinated approach to managing an entire operation, development of skills and knowledge about the 10 essential services among our staff, and a shift from program measurement to a balanced and cohesive management model, and a shift from categorical to a scope targeting system-wide capacity, processes, and outcomes. And that's how we wound up moving toward what we call our Performance Excellence Council. Next slide. So we wanted to create an integrated approach, vertical and horizontal, to improve and manage our public health service performance. We wanted to cross-develop public health skill sets by assigning staff to projects in domain outside of their comfort zones. One of the howls that we heard constantly from both managers and people assigned to our FAB efforts was, well, I don't know anything about this domain. And our point was, if you don't know anything about this domain, you pick whichever domain it was, whichever essential service, because the domains and essential services are almost the same thing. That's a problem. We all should know something about each one of the essential services. We all should have those ideas in our head as public health employees. So we wanted to identify and train staff in broad skill sets so they can move about within the system and know our own resources. And we wanted to orient staff members to the meaning of public health as opposed to medical care. Because public health is sort of the anti-medical care health system. Our goal is to put medical care out of business. If we do our job right, we would need less medical care. We would need fewer hospital days and so on. And, trying to take that orientation, if you will. All right, next slide. So here is the Turning Point Public Health Foundation model that we used for the building of our performance management system. And the first point in this is that you have a culture of leadership. and a culture of performance management and performance improvement. And, oh, by the way, when I talk about performance management, in my own head at least, I automatically include performance improvement and program development. They're all, you can't just manage your existing programs. You have to improve and develop new things when needed as well. So you have standards, measures, the reporting of your progress, and quality improvement action. And clearly in the Turning Point Public Health Foundation model, quality improvement is a component of performance management, and it takes on a new role compared to what we used to have. And I hope all of that makes sense. And you can find the Turning Point programs. They have several versions of this orange and black graphic out there, but they all say pretty much the same thing. So our Performance Excellence Council, you see I stuck in the middle there, is designed to do all of these things, creating a culture and leadership of our organization. Next slide. So we had, at the time, siloed plans and processes. We had a continuous quality improvement plan. We had a public health strategic plan, public health accreditation plan, community health improvement plan, public health budget plan, and so on. And I could add more in here, but that's enough. And they were all pretty much independent of one another. So the move was to create, next slide please, all of this into a single model and bring it together into a performance management system that we call our Performance Excellence Council, to kind of mirror, again, Ventura County's Service Excellence Council. We're using their terms to show how we fit in. Next slide. And then again, emphasis, and I'm putting this in twice, to drive home the question of to what extent do we do these essential services, and to what extent do our staff know about this model and know that this is what they're supposed to be doing in their jobs. Next slide. So, ta-da! There's actually two versions. This is the first version. Here is our performance management system structure. We have the public health planning and deployment champions. And again, if you're familiar with Lean Six Sigma, deployment champion, we borrow the phrase from Lean Six because, again, it fits back into the county's model. And deployment champions deploy the system. And typically you think of a deployment champion as being one person, such as the director of a department. But in this case, we have a committee of basically the top management in the department, and we are the collective set of deployment champions. And we maintain, and the definition is maintain administrative and management capacity, and maintain capacity to engage the public health governing entity, our Board of Supervisors. So we handle things internally and report out to the Board of Supervisors on what we do. Then underneath the circle, we have the Performance Excellence Council chair, co-chair, and coordinators. And the first year out, there were three of us who were the chair and co-chairs. And we have coordinator, staff support. And then we assigned 2 or 3 of our managers to each of the 10 essential services. And the initial structure was there would be 2 or 3 people, and they are assigned as what would become the champions in Lean Six Sigma terms, the people who oversee projects, not conduct them, but oversee them. And people were kind of just pretty much randomly assigned into those different boxes. Now, again, there was some howling going on because somebody might say, well, I don't know anything about assessing population health status, for example. And the response is, well, if you don't know anything about it, you're a member of public health, and gosh, maybe it's time to learn that, because we all need to be able to do all of these kinds of things. Then they, pardon me, if anyone in our operation, even our stakeholders, can suggest projects that might need to be done to improve or manage our operations better, those suggestions go to the council chair and co-chairs who coordinate all suggestions, and then take them in a monthly meeting to the deployment champions and talk about, here are ideas that have come up, here are issues that people are talking about, Should we do something about this? The deployment champions decide whether or not something's a go, or whether it should be set aside for the moment, where in the priority any particular project would be in our laundry list of all the things that need to be done. The projects then are handed off to the appropriate team leads, on the essential service leads, and a charter is written and a team is formed. The event and project implementation teams are formed and brought together, and they work on the project. To date, last count I knew, we had 27 different projects that have been suggested since we began this. We kind of held everything in abeyance until we got through the FAB accreditation. And now we've implemented 3 or 4, or maybe it's 5 different projects, and kind of put them into the appropriate box with the appropriate managers and subject matter experts brought together, to work on these things. One of them, again, is the new employee orientation project, which, the agenda and the outline for that training session has been developed and now needs to go back to the deployment champions for approval, or tell the group, wait a minute, you need to redo this. Okay, and then this particular version was decided to be a little too complicated and a little too hard for some people to grasp, so we made a modification in it. I think either way is fine, and we can show you the modification in the next slide. So instead of having 2 or 3 people assigned to each of the individual domains, essential services, we now have 3 different groups of leads, and kind of a larger set of numbers, so that at any given point in time, some particular lead might be busy, and we can call on another person in the collection of 3 or 4 or 5 leads to implement and go forward with the project and oversee it and make sure it happens. Next slide. So our administration, management, engaging governing entities, we see that we kind of rounded up domain 11 and 12 into part of the performance management system. And you see there's a crosswalk that this particular slide is supposed to represent, how the different domains from FAB fit together and actually touch one another. They supposedly are free and separate and distinct, but really there is a lot of crosswalk between the different domains. And this just shows how they all tie together. And next slide. So deployment champions, domain 11 and 12 in FAB terminology, they're assigned by the department director. They identify, again in the jargon of Lean 6, the value streams. And value streams are those broad themes and strategies that need to be worked on and need to be developed. And they lead to current improvements or new developments. They prioritize the improvement and development projects, working with the Performance Excellence Council chair and co-chairs that are in that little middle box on the graphic. They review progress and take action on resulting reports and outcomes, and assure that there's a balance in the assignment of team leads and members. If a special focus is established in one or more, the deployment team may assign leads and members to assist across domains. So if we really get heavy into a particular topic area, we might realize we need to make sure that the workload is reasonably evenly distributed. And another part of this is to assure that every year that we've worked on something in each of the essential services, that we're not letting one topical area slide because we're totally focused on something else. We need to be moving the whole department forward in the essential services. Next slide. Okay, so our principles: integrate a performance improvement and management toolkit with the 10 essential services, identify, maintain, and improve community health, safety, and wellness, continuously look for and act on excellence opportunities, ongoing integrated cycles of assessment, planning, which is called DMEDI in Lean Six Sigma jargon, and evaluation processes, which is DMAIC, into a single structure and align it all with the county service excellence approach. We have base strategies on measurable, knowledge-driven data. We conduct risk, threat, and weakness assessments to help us decide what areas need to be worked on. We want to continually increase our workforce competency with staff members participating in all aspects of performance excellence. And that's one of the hard principles, is that a particular staff member who works wherever they might work could have some particular piece of knowledge or insight about a topic, and they can get called upon to work on a project. And if we're all doing this together, a basic operating principle is if we really need the person on a project, we have to figure out how to make sure that they can work on the project without the manager being able to say, well, I'm sorry, I can't give the person up now. Because if we do that, then we just kind of wreck the whole structure. And there's always something that needs to be done so that we can improve our operations. And mobilizing our community out of Domain 4, as appropriate, community members and service recipients can participate in identifying and responding to community health and wellness needs. And they could even wind up working on projects in the long run. Next slide. So the basic role structure and process is outlined here. Going down the side sort of corresponds to that graphic that I had earlier with the circle and the boxes and all. The deployment champions at the top, Performance Excellence Council leads and coordination, the domain leads, those are the 10 or the 3 groups in there, and then at the bottom the project participants and people who actually work on a particular project. Across the top, again, we go back to the turning point structure, performance standards, measures, reporting of progress, and quality improvement. And then that's the basic structure. Now it gets a little complicated in the next slide. Same idea, but showing it in a slightly different way. So next slide, please. And I'm trying to use the same color coding, if you will. I think it's about the same, to show like who does what in the whole process. So the summary of responsibilities across the top, again, standards, measurement, progress reporting, and CQI activities that circle back on themselves in a continuous loop. The deployment champions, I won't read this whole slide, but the deployment champions, again, there's their role. The chairs have their role with the coordinators. The 3 core function teams or 10 essential service teams, mattering on how you want to design things, work on performance standards and measurement. And then everybody at the bottom can be involved in actually conducting program-level performance management, systems-level performance management, and so on. And the real shift is to look at our operations as a system, not as isolated programs. An example I use from my old days in mental health is our mental health inpatient unit. And this was a real case, and tragically, I'm sorry to say, but you have somebody, and the numbers and everything else is fake because, confidentiality and all that. But, somebody comes into a mental health, inpatient unit, and they're given a GAF rating, a Global Assessment of Functioning rating. And 0 is dead, and 100 is you're the best functioning person on the planet. Well, typically people will come into an inpatient unit with, I'll make up a number, a 25, which is pretty, not doing very well. And after 3 or 14 days or whatever, they're medicated, they're talked to, they make things out of macaroni on pieces of paper, whatever, and they leave with a GAS rating of 75. Well, they got better, right? Well, but 48 hours later, they went out and stood in front of a train. At a program evaluation level, the program is perfectly successful. At a systems level, we have a systemic failure. And it's making that shift from program evaluation and program management and improvement to systems improvement and systems management, and looking at how all of our pieces of our puzzles work together, how we collectively serve the same people, looking for what I used to call our $1 million clients, and focusing on them as a target population to reduce their level of need and services so that we can spread our services and resources more effectively, is where we want to go with this. It's all about really systems theory and thinking systemically. Okay, next slide. I think we're getting pretty close. So the results to date. we used this structure to develop our Domain 9 of the FAB accreditation proposal, as I've already said. We received really high praise from the FAB site visit team, and we're using this to deploy improvement projects that have been identified through the FAB accreditation process. And that was the other critical part of this. They wanted to see that not only did we have a structure in place, but that we were already actually using the structure. It had to be more than just on paper. Okay, next slide. Staff members are much more well-versed today in the public health essential services and have more awareness of the range of public health services to our county. Again, here we have 27 projects that have been suggested. 4 have been deployed so far. When I put this slide up, I need to find out how many we have now. Okay, next. So creating a performance improvement and management culture. And I prefer the acronym of PIM to the other acronym. So this shift to integration creates a new culture of performance improvement and management. Our managers and staff have to think and work outside their own silos. Projects can have broader utility than just within individual programs, and there's a real advantage to, instead of having programmatic CQI projects where a program works on a particular thing within its own domain, if you have people from different parts of the operation working together, we can discover where there's cross-fertilization of learning and opportunities, and realizing that something that is being fixed in one place can also be the same ideas, same approach could be used somewhere else as well. And another advantage is if a program realizes something needs to be done, they're not stuck just having to do it themselves, thank you very much. They can call in outside resources and say, look, help, we need help over here. And if it's prioritized, then they can get that help from other parts of the operation. Next slide. And that's it. That's my story, and I'm sticking to it.
Well, Dan, that was fantastic. It obviously is very complex, and a lot of work went into it. And it makes me think, too, not only how important it is for us to be thinking systems-wide, both for kind of our internal operations, but it's also basically the same at the root of multi-sector partnerships as well. So
yes, absolutely, yeah.
Yeah, exactly. I just think this is kind of the way we need to start thinking about all of the operations, all of the things that we're doing. I'd like to open it up for questions and comments and anything else that folks would like to talk about while we've got Dan here and all the work that he has done.
Hi, Dan. This is Tamara in San Diego. I have some questions about, you showed the one logic model for more of the generic, if you could maybe want to bring that back up.
Basic role and structure, yeah.
Yeah. Did you use that for all the programs to develop performance measures for their programs and leading those through the logic model process toward the community indicator data, or how was that done?
We're in the process. I mean, first we got through the accreditation process, and now we're really beginning to launch this approach. And the Performance Excellence Council leads, working with the deployment champions, we need to really look across the essential services that we're supposed to be providing, and identify where the standards are, where we might think or we need to have improvements, and then decide on prioritizing how we need to go about that, because there are only so many resources available at any given point in time. And then as those projects are are prioritized, then deploy them down to the domain leads, who then form projects and organize the participants and all. And again, one of the first big ones out of the gate for us was the new employee orientation, where we realized that we have people who come on board who, especially if they come out of more traditional health or medical kind of setting, and they understand a medical model, they understand that side of the fence, but we don't have a good understanding on the public health side. And in fact, one of the people leading the new employee orientation project is in exactly that situation. 30 years as a hospital nurse. And she talks about in kind of a humorous manner, but just like, wow, it's really a culture shock, to come into a very different setting, even though we all have health in our name. So that's how we're really launching the process and going through it. And we will have, actually, I just got the report from that of what the agenda is going to be for the new employee orientation, and now need to take that back to the deployment champions and say, okay, here's what they've come up with. Does this meet our strategic goals? And if not, then we need to have them tweak it. If so, then you go forward and begin the process. And part of that particular operation is we're going to pilot it on a few guinea pigs to see how if the training really works. That, I know that's already part of what's being proposed there. Does that answer your question? Or?
Well, no, not really. I was really asking about performance measures and how that leads up to getting at the community level indicators. And for example, a lot of programs already have performance measures that they're managing their programs to because they've been dictated either by the CDC or the state. For example, one of the ones we look at are the patients who complete their treatment for tuberculosis. So we have measures around that, and then leading to the larger indicator of decrease in morbidity due to that type of disease. Do you have those measures, and if so, what system are you using to manage those?
Okay, well, yeah, there's a distinction, I guess, between the systemic kinds of things, and then something like in that particular case, specific TB, responses. We have a TB program too, and we have specific kind of performance measures as well, and those are set, they're mandated, have to be met. So the question is whether or not that particular program is meeting those particular standards. Now, if something comes up where they needed help on getting the data or needed help in being able to respond to a demand from a funding source, for example, they would be able to come to the PEC and say, look, we need help over here on this particular project, for example. That would be the advantage of having a sort of a systemic performance management system rather than a siloed programmatic continuous quality improvement program. And then we also need to do our community health assessments, the health impact assessments and so on, and look at how the different programs might all have a hand in a larger kind of measurement area.
Tamara, is that good, helpful, or do you need a little bit more?
No, that's fine, thanks.
Okay. Open it up. Other questions or thoughts?
This is Susan in Santa Barbara County. And Dan, one of the questions I have is, could you give me a sense of the number of people involved in these teams and these roles, and how that fits with the size of your department?
Pardon me. Okay. Hi, Susan.
Hi.
On any given project, we have our leads assigned, okay, and that's a passive role. I mean, you're assigned a lead, and until something happens, you're not doing anything with it. Okay? But then a project comes up that rises to the level of being prioritized for action, and whatever the particular topic area is, and let's pick one at random, developing policies and plans. And so we have the managers assigned to the develop policies and plans box. And now the Performance Excellence Council chairs meet with those leads and say, okay, the department's decided we need to work on project XYZ. we develop a charter, or the design of the project, and charter is again a Lean Six Sigma terminology, and get that ironed out to where it's very specific and you know exactly what needs to be done, and then identify the staff who would need to work on that, and they could be from anywhere in the department, and it could even be outside resources. One of the things that we have an advantage with is because we've used the Lean Six Sigma model that the county adopted, we can call the CEO's staff assigned to that and say, hey, look, we need a facilitator, or we need a subject matter expert on something that maybe out of the DA's office, whatever it might be, and bring the team together and have them work on developing the project. And again, part of the strategy here is not to create more work, but to organize a way to get the work done that is sort of beyond the everyday routine of crisis response that most of us wind up being in. It's I call it taking time to save time. And organizing things in a way that we can save time and save energy and save efforts and be more efficient about the work that needs to be done, rather than just handing it to the usual suspects. Does that make sense?
It does. I just wanted to get a sense of the numbers. I recognize that people are not active in their roles until there's a specific project.
Right.
But you have this council and you have these champions. Mm-hmm. And you have these domain leads, so there are people who have different roles at different times. Could you give me a sense of the number?
In the assessment leads, policy development leads, and assurance leads, there's something like 20 people total spread across there. I have to go pull up my charter and get the head count.
And, that's about right. This is Rigo Fargas.
Yeah. There we go. Do you have the head count?
Yeah, it's about right. About 20 for the team to call upon, but then, of course, after that, then they would call additional members depending on the project, as you mentioned.
Right, and so on the new employee orientation project, there's something like 11 or 12 people who are involved in that, and they've met maybe 10 times over the course of putting the thing together, and they're kind of spread across the entire department. And we even called upon curriculum development experts that work for the county and have been involved in other training development things, and we're able to call on them to help us really bring make it be just a curriculum that makes sense and and meets those kinds of standards as well.
Dan, this is Siri. I would say the projects range between 2 and 20 staff, depending on what the project was. That would be an average number, no less than 2, but not typically more than 20.
Mm-hmm. And they can be as projects can be as simple as you have to meet for an afternoon and take care of it, or something that really needs to be developed from the ground up, and providing a structure to make that happen.
Thank you.
Okay.
Other questions?
Nope.
I'll jump in. I've got actually a couple questions, Dan. First of all, I'm just curious, it's a big shift for people, I think, to go from a programmatic viewpoint to a system-wide viewpoint. And I'm wondering, how has that been, how have people adapted to that, and how are they kind of managing that, do you think?
You're right, it is hard. And, that's, having worked systems and tried to develop systems for most of my career, it's a big shift. And as much work as the FAB accreditation process was, I think it actually helped us collectively to start thinking more systemically. So the pain and the agony of all of that went into that, I think really did help set the groundwork for people to begin to think more systemically. And it's a distribution. There are people who are already very systems oriented, and other people who are just more programmatically oriented, and that's okay. But to see, helping people see their work in context and begin to understand their work in context. And I've been working with our public health clinic staff, for example, and they're providing immunizations, and to their credit, I mean, they're dedicated people who are out there trying to poke needles in little kids, and they historically see their work as they are serving an individual child, for example, just using kids in IZs, and working with them to help them understand that they're not really, when they give an immunization to a child, they're really serving the community. They're really working to protect the community. And it may sound like, well, so what? I mean, yeah, you're right. But I think that working that way and seeing their work in that kind of a context helps them do a better job, because they're thinking about what's going on around, and they're thinking about what about where does this child live and what's going on in that area, and is this kind of a high risk population, and do we need to do something maybe a little different? Maybe we need more outreach. We're doing an oral health thing right now with trying to get varnish on kids' teeth, and really putting together it's not a big thing, but it's a small campaign to increase dental varnish being done in our clinics, because it really is a form of immunization and getting the word out and so on. So I think that at least having that sense of the context that you work in, rather than only examining your own foxhole, use a bad war analogy, does help shift how well things get done.
Yeah, I can imagine that more holistic thinking really kind of probably fires up people's thought and probably recommendations for other projects, and provides a lot more meaning too. My second. Go ahead.
Well, I was going to say, yeah, and that I think you hit on an important word there. We all want to find meaning in what we do, and it's easy to get just kind of down in the daily cycle and the daily drudgery. But if you understand that your work truly does have meaning, and again, not just for the individual person that you might be working with in that case, but for the whole community, you're protecting your community, you're protecting your own family, you're protecting all of us. At least for some of us, that's important.
Mm-hmm.
Yeah.
Mm-hmm. My second question is quick. It's kind of a comment and a question. I was shocked to see your slide that talked about how much time do we actually end up spend on strategy.
Oh, yeah.
It was just like, my stomach hurt when I saw that one. And I'm just wondering, kind of given that shift, I'm just curious, are you guys now monitoring like how much more time now is going into strategy, or how is that measure being affected?
Well, you know what? That sounds like a proposal that needs to be made to the deployment champions to monitor these things. That sounds like a perfect project. And you're right, but this slide, the turning point, that's not my data. That's data from whatever. We could argue with our research, but that's research that shows how little time gets spent in organizations on these kinds of things. And it would actually be interesting to see if we could figure out an easy and efficient manner of measuring how much time we do spend on these kind of topics and projects.
Yeah, I think that's fascinating.
Can I just chime in for a second? This is Tamara in San Diego. When I looked at that, we have been using our general management system as our performance management system in San Diego since 1997. And I would say we were looking at this one slide and thinking, we definitely, having had that system, has had to pay off, because we don't see that same we don't see that same breakdown. We have definitely, I can say, more than 5% of our workforce understands our strategy, and 25%, 100% of our managers have incentives linked to strategy. Their whole pay for performance system is based on strategy. And so, my point being is, once you have a performance management system in place, you see that these percentages will move in the desired direction quickly.
Well, good. Yeah, and maybe that's part of it. It's not the one magic bullet of one particular model, which I don't agree with. It's, do you have a system? And if you've got a system, it'll probably help you. We've done it one particular way. There are probably other ways that would work as well too. Yeah.
Right. You can't manage if you don't measure, right?
Right. Yeah.
So, well, I see that we're at the close of our time. Dan, I really want to thank you for taking the time and so much thought to present this to our group. And I really want to extend congratulations again to all of Ventura on your accomplishment of being the first local health department in our state to national accreditation. So thank you very much. And thank you all for joining us.
You're welcome.
Okay.
Thanks,
Bye-bye.
Dan.
Thanks.
Okay.
Bye, everybody.
Bye-bye.
Thank you, Dan.